problem. Then what do you want me to do? You want me to upload it to like Google Drive and then you'll move it over?
That, or you can also put it right onto the Think Tank Facebook page or onto YouTube and send a link. We'll
Okay.
figure it out later. No
All right,
worries.
we'll talk about it.
Okay. All right. Well, I will get this started. I'm sure people will sort of slowly roll in, so we'll just kind of keep an eye on that. But thank you for those that are already here to join. This is the continuation of our think tanks to learn from each other, and I'm really grateful for Ursula hosting this one today. We have some upcoming events. So in July, I have Jen Kay who's going to do something related to like speaking and public communication and things like that. In August, we're going to have two presentations. Lorenzo is going to talk about infant mental health, and then Paige is going to talk about sort of, she's blending the massage world and personal training. So I think that's going to be an in-person interactive. September, Amy Vanderlyn is going to do one on pelvic health. October, Paris is going to do one. Chiropractic infant health and moms maybe or something, whatever topic she decides. And then November, we have a speech and language pathologist, Caroline, that's going to be presenting. And then December, either we'll have a holiday event or if somebody wants to present, maybe we'll do both and then it'll go from there. So I started the think tank in 2012, 2013 or something to pull like-minded practitioners together and learn from each other and create community. And so I'm really grateful to be part of that. And Ursula here to share and teach and connect us through this virtual community. So I'll let you take it from here. And I'll mute myself and then I'll let you guys kind of figure out how you're going to ask questions and circle it up at the end.
And I gave you co-host so you could let people in while I'm talking.
Okay, perfect.
Thank you. I have done this presentation before. It does take me an hour. So rather than everyone doing introductions about who you are, what I'm going to request is when you ask a question, and I just want you to yell out when you have a question or unmute yourself, just tell me what your background is so that I can make sure to answer the question as it relates to your practice that you yourself are in. And I'm going to share my screen. So today we are talking about birth trauma, and I'm specifically talking about it from two different lenses. I'm going to be talking about it from the medical lens as well as the patient lens, which is unique in that you're going to see that there's definitely some disconnects between the two of them. A little bit about me, yet another picture of me. I have worked with over 5,000 families in 27 years. I've attended over 1,600 births. I am a full spectrum doula, which means I do everything from birth through postpartum, as well as fertility and loss, which is something that's near and dear to my heart. Uh, so happy to answer questions as we go through all of that for you. Where I really want to start is quite simply with the definition or the idea of what trauma is, which is surprising to a lot of people. Trauma, quite simply, is in the eye of the beholder. And this is why we're going to have a disconnect as we go through these storytellings tonight. The bottom line is the person who witnessed the trauma or participated in the trauma, they own that trauma. It can be occurring at any point. It could be in the fertility process, it could be in the pregnancy, it could be in labor and delivery, it could be even in the postpartum period, which we classify as the first year after giving birth. And that trauma can be experienced differently. So, mom might say, I had this trauma. Partner might say, I witnessed this trauma. And the provider might say, I saw this, but it was not traumatic. All right. No matter how we go about this, the events are going to have short-term and long-term repercussions, and we're going to talk about that just slightly. Maternal mental health, just a few facts for those of you who might not be aware of this. 1 in 5 women, or 20% of all birthing people, report some sort of mistreatment during pregnancy and childbirth. 33% actually report using the word trauma during their childbirth experience. And then, interestingly enough, 75% of those that had the trauma are untreated and they don't know that they can get treatment. They don't know where to get treatment. They don't know that treatment is available to them, or they feel that by seeking treatment, they're going to be judged. So they do not seek treatment. And then we have compounding effects from there. High risk groups, as many of you can expect, people of color, the Black and Brown community, those that are living in poverty, military personnel or their spouses, non-native speakers, people who have a history of prior trauma, and of course, individuals who are medically complex for a variety of different reasons. And guys, I'm going to just keep going until you stop me. So I love this image because as a doula, one of the things that I see is that an individual has previous trauma. They do not disclose it. And then when we get into the childbirth room or in pregnancy or postpartum, something happens and all of a sudden their bodies react very somatically. And all of a sudden we see trauma in the body that they have not disclosed to us. So, for example, a woman who was raped may not have had any vaginal exams in her pregnancy. She may be admitted to the hospital. The provider might go to do a vaginal exam, and all of a sudden she's like a hissing cat attached to the ceiling, just having a very visceral reaction to what's going on. And anytime that we experience fear or trauma, but specifically fear or anxiety in labor, it shuts down what is going on and it keeps labor from progressing. And that then increases the amount of interventions we have to do. And then that leads to a less than ideal outcome, if not trauma. Obviously, anyone who has a history of anxiety or depression would be more likely to have event trauma. Obviously, also sexual, physical, mental, or emotional abuse, domestic abuse, home invasion, disasters, facility exposure, suicide, death, war, or political violence. So, as a doula, we ask questions about why did you pick this provider? Why did you pick this facility? And then, in the event that that facility is not available because they're on diversion, because they're full, or there's a natural disaster going on and they don't have rooms, we may have to pivot to another facility. And so, preemptively planning on what is our backup facility can make a huge difference in making sure that the clients are kept into a safe space. I had a client many, many years ago. Her name is Jade. Jade was delivering at Sibley in DC, and we were talking about what was our backup plan, and I recommended GW. And what I found out is that a few years prior, her husband had been suffering what they thought was a heart attack. They showed up at GW. They wound up in the emergency room for 4 hours because of what was happening in the emergency room. And their impression and their memories of GW was less than ideal. And so automatically they would assume they're not going to get the care or their quality of care that they needed there. So we nix that as our backup plan. So anytime we can have these conversations up front and we have a client who's willing to disclose and willing to be open with us, it can allow us to work with their situation and or refer out to different providers to help us what those situations might be. It could be myofascial work, it could be a chiropractor, it could be acupuncture, it could be any number of things that might help us to move through this space, give them a better outcome. What we're always worried about is the ripple effect. So one drop in a pond creates a series of ripples, and those ripples have short-term and long-term side effects. So patients will report an emergency C-section or an emergency admission to the hospital, labor starting and stopping, or going to the hospital thinking they're in labor and then being sent home is traumatic. A baby having a NICU stay that they were not expecting, or a longer NICU stay than they were expecting. Things happening unexpectedly in the birth. Maybe their provider's not there, they're suddenly out of town. Maybe their mother showed up unexpectedly. Maybe their mother did not show up, right? We don't know what these situations are oftentimes until we're in that moment, unless we ask questions to expose them. So when we think about medical trauma from the provider's point of view, we divide it into infant and then the parent. And it's interesting to note right down here on the bottom, the likelihood of there being medical trauma is less than 1 to 2 in 1,000 births. So statistically, not a big number unless you're the person experiencing the trauma for obvious reasons. So for an infant, the medical community considers these to be traumas. So a scalpel injury to the baby's face, typically during a C-section, a subdural hematoma, or basically like a big blood blister on the top of the baby's head, caput, which is swelling from the baby's planes of the skull overlapping and staying in that position for a long period of time. Neurological issues such as spinal cord issues or a brachioplexal injury from, say, a shoulder dystocia. Obviously, orthopedic injuries, a fractured shoulder, a fractured arm, a dislocated arm. And of course, the ones we don't want to talk about, which are demises. For the parent in the medical world, when we have anything past a type 2 tear, so a type 3 or a type 4 tear. So a type 3 tear goes to the rectal muscle. A type 4 tear goes through the rectal muscle. And you can imagine that that is a significantly longer healing time. So excessive tearing, damage to the muscles, whether those are muscles that are around the urethra or the bowel, organ injuries, prolapse, tears that go up into the clitoris or involve the urethra, needing a blood transfusion, death, being scared that they were going to die, right? These are pretty straightforward when you think about them clinically. There are risk factors. So when you're working with a client, these are risk factors for you to be aware of that puts them at increased risk for trauma. So macrosomia would be a baby over 4,000 grams. Micro or macrocephaly, a small head or a large head. Small for gestational age, and small for gestational age is considered less than 10% on the curve, but most providers induce somewhere between 3 to 6% for small for gestational age or large for gestational age. The concerns with both of these are prematurity and a NICU stay, obviously congenital abnormalities, and most of those we know today from ultrasounds ahead of time, but there are still a couple that are surprises at delivery. Too much or too little amniotic fluid, and then of course the issues of a baby that's being misaligned. So a baby that's breech, a baby that's laying sideways in the pelvis, or a baby that's trying to come out face or brow first, obviously has increased complications. And those, some of them we know ahead of time, some of them we don't know. For the mom, gestational diabetes or type 1 diabetes, again, low or high amniotic fluid. Size discrepancies. This is a kind of a good one for you guys to know. There is a 20% error in fetal size estimations. So we can estimate that a baby might be 11 pounds and the baby could be 9 pounds or 13 pounds at delivery randomly. So these size discrepancies are not terribly accurate. But when we have a size discrepancy, we're more likely to have pelvic dystocia or the baby getting stuck in the pelvis. And we oftentimes see that with obese mothers or obese babies. Use of instruments, forceps, vacuum, C-sections obviously increase the risk for trauma, as well as a prolonged labor. And by prolonged labor, the textbooks mean anything over 36 hours, or a precipitous birth, which is anything less than 4 hours from start to end. And that's kind of crazy when you think about it. People are upset over a fast labor, but a fast labor for a lot of parents is kind of like a roller coaster ride where they're holding on to that bar and they're screaming as they're going down and they're feeling out of control and that they don't have autonomy in those situations. And on top of that, providers have a tendency to disbelief because we don't see a lot of rapid deliveries nowadays. In my whole presentation, this is one of my favorite slides. So bear with me as I go through this. Depending on who you talk to in the birth world, there's 4 Ps, 6 Ps, or 12 Ps of labor, but they all start with the same 4 Ps, okay? So they are passenger, passageway, power, and psyche. So in my experience, the passageway, the pelvis itself, is a problem in about 10% of all births or less. And that is either due to injury, car accident, broken pelvis, something along those lines, or it is due to genetics. All right. The Baby, the passenger, is misaligned in about 25% of all births, statistically. So knowing what position the baby's in before we go into labor can help us to work with providers, again, massage, acupuncture, chiropractic, just off the top of my head, to try to get that baby as aligned as possible to minimize some of the complications for the family. Power is also a problem in at least 25, if not 35% of all births. And that is the uterus being strong enough to contract on its own. And things that would affect that is too much amniotic fluid, not going into labor spontaneously, instead being induced, a baby that's misaligned. And we oftentimes also see this with IVF babies as well. The neat thing about power is that we do have medications out there called Pitocin. Midwives call it vitamin P. When used appropriately, it is a tool that can help to strengthen the contractions that can either help to get the baby out or to rotate the baby in order for them to come out. We are less likely to need this type of intervention when we have a client who has been doing body work throughout their pregnancy. They've also dealt with any emotional or mental trauma they might have. And when we know what the baby's position is, we can help the parents to get into ideal positions to get the baby out. Psyche is the trickiest one. And I will tell you that psyche is the hiccup in labor at least 65% of the time. I've had women, actually people in labor, stop their labor because all of a sudden they look at the clock and they realize they are seeing patients in 15 minutes. Or maybe their provider's out of town, or maybe they have a backup doula and not the doula they were expecting. I had a mom whose baby fell at the playground while she was in labor, and the child broke its leg and its pelvis, and dad had to leave to go to another hospital to get the child stabilized, and so her labor stopped while dad was gone. I can tell you stories like this, but when we can have conversations with our clients ahead of time, get consent and their histories, we can start to work through some of these things and prevent them. So by asking them what is in their control and what is not in their control, they can navigate their pregnancy, their birth, and their postpartum differently, potentially avoiding some of this trauma. In medical speak, other things that we need to be aware of is not just the injury itself, but perception of danger. So fear of injury, fear of death, either to the pregnant person or to the child, in and of itself is traumatic. And we have a whole list of things here. Some of them I mentioned before. So PE is preeclampsia. PIH is pregnancy-induced hypertension. DM, diabetes mellitus. Obviously, complications from anesthesia, maybe they have the redhead gene, or maybe they're a runner and they have really tight ligaments in their back, and so placing the epidural is complicated. If they are an IVF conception, there is a likelihood, about 20%, that that placenta will be what we call sticky in this business, meaning that it doesn't release on its own, and we might have to go in and manually remove it or remove it with instruments. Obviously, that increases risks for things like hemorrhage, an unplanned hysterectomy, and again, death, fetal distress, stillbirth, and infant death, prolonged NICU stay are all reasons for trauma. Emotional trauma is very different, however. So you're going to see some of these things are the same, but I want to give you some clarification. So for people in labor, perceiving that they're in overwhelming pain and the providers not acknowledging their pain or not acknowledging that the medications might not be working or denying them medication. I don't know if you guys are aware of this, but in many medical textbooks until about 5 years ago, there is a page in there where it talks about different ethnicities and how they respond to pain. So Asian people don't respond to pain. They won't report they're in pain. Black people don't need pain medication because they're different. And it went on and on. That has been removed from medical school literature, but a lot of doctors still believe and practice some of these things. If we have a C-section, there's the potential of nerve damage, or if we have vacuum or forceps as well. And then hemorrhage, let me just give you a couple of clarifications. I'm less aware of this in Arizona, but I have practices in Maryland, DC, and Virginia. And so there's a difference between estimated blood loss and quantified blood loss. So a lot of hospitals are now actually weighing the Chuck's pads, the blood clots, the gauze pads, and then removing the weight of the material to get qualified amounts of how much blood was actually lost. So in a vaginal birth, we expect about 500, and in a cesarean, anywhere between 1,000 to 1,500 is considered normal. And when we can estimate or quantify how much blood has been lost, then we can start paying attention to the necessity to give supplemental blood or packing the vagina or the uterus if needed to prevent more further complications and more trauma. Patients, they themselves in today's world are choosing not to take childbirth education classes, or they're choosing to do YouTube and social media education. And so a lot of them are unprepared for the fact that as the baby is descending through the pelvis, they will defecate on the bed, and that is normal and natural. And providers are excited about that because it means the baby is moving. Women and anyone in labor will vocalize. Some people moan, some people scream, some people bite. And for a lot of people, being unable to control your vocalization is traumatic. It makes them feel inadequate. Sometimes they might have unwanted interventions, such as a continuous epidural, or maybe an induction of labor or a C-section they didn't want. It is not uncommon for providers to not be in the hospital while their patients are in labor, and instead they're at their offices. And especially when somebody has an epidural, the nurses will call the doctors and say, okay, she's 10 centimeters. It's time for you to come over now. And then the patient needs to wait for the provider to arrive to push their baby out. Or maybe there's not, all the providers are busy on the floor. Seen this a few times. Maybe the baby, when born, they're born stunned, or they need some respiratory help support, so we don't get to hold them or see them immediately. That is traumatic, as well as feeling helpless. Especially when you have an epidural, people are surprised that they can't move around in the bed, that they can't get up and walk around and change their positions. The staff oftentimes only comes into the room every 45 minutes, an hour, every 90 minutes or 2 hours to check on the patient. So they're not being heard and they feel intimidated and obviously also in pain, because whenever you're emotionally stressed, you're also going to be physically stressed. Questions as I keep going? Anybody? All right. So psychological. We see a lot of perceived threat here. Um, Individuals feeling that they're not being heard, individuals feeling that they're being ignored, or they're not being treated as individuals, rather they're being treated within the parameters of medicine. So obviously when someone has sexual trauma, that is going to increase their needs. Unwanted interventions, epidurals, triggering previous injuries, bed restrictions, such as being in the bed and requesting the epidural and wanting a dense epidural, but now you're trapped in the bed and you can't get out of the bed because of your history. It is not, hospitals have now a practice where they try to come into the room when there's a shift change, and they try to talk in the room next to the patient as they give report, instead of doing report in the hallway. And for some patients, when the staff is gathered bedside giving report, talking about whatever is going on, that itself can be traumatic, especially if there's some sort of a history there, of people gathering over them, looming at them, bright lights. There's a million different things. Lack of agency and lack of control are the two things I hear consistently from clients when they talk about trauma. And much of that is around failure to receive informed consent. So we like to teach clients an acronym called BRAIN. The acronym is what are the B, the benefits of this drug or procedure? R, what are the risks of this drug and procedure? A, do I have any alternatives? I, what does my intuition tell me? And N, what do we do if we do nothing? And it's unfortunate, but a lot of providers, when they come into the room, they don't automatically share this information with the patient. And the patients have to speak up and ask for these questions. And when they don't get those answers or they don't know they can ask these questions, then oftentimes they feel pushed, rushed, not seen, not heard. Um, they feel guilty down the road. And obviously, for the partners, there's the witnessing of this event that can be very traumatic for them as well, whether that's partner, mom, doula, friend, whatever that is.
Um,
Yep,
Hi.
go ahead.
Yep, question. So I actually, I'm actually a trauma therapist. So
Awesome.
yes, so kudos to you that you gave that description because indeed trauma is a nervous system response. It is not the event itself. And that's a great distinction to start out with. Um, I work a lot with people who years after these things have happened and we're unwinding from all of the residue of these kinds of traumas that are, by the way, held in the body continuously until they are released.
Mhm.
So my question to you is, um, to what degree, because I'm not on the front lines in hospitals or with pregnant people, or what's happening in terms of creating a more trauma-informed hospital situation? What's happening in terms of a more trauma-informed nothing?
So
That's
basically
one.
there's like two things going on. So one, a lot of hospitals are getting baby friendly designation, which means that they're encouraging breastfeeding and they're encouraging rooming and postpartum. So some hospitals are working towards that designation, and some hospitals, once they get that designation, they drop it. Just because if you're a baby friendly hospital and babies are supposed to stay with the parents, but the parents are still medicated or drugged, they cannot take care of their baby properly. And those are where we have injuries. There are a few hospitals that are doing trauma education. I'm not aware of any in Arizona. I can think of Washington, DC, GW in particular has spent a tremendous amount of money bringing people in, educating. And a lot of that started with Black Lives Matter and
Mhm.
trying to educate themselves around the Black and Brown community. And then they moved into the LGBT community, and then they moved into the trauma area. Uh, it is expensive. It's
Mhm.
hard.
Mhm.
The staff just wants to get their job done. They don't want to be told they should be doing it differently. And so it's not being addressed. It's really
Wow.
up to the doulas and to the providers when they notice it to make a referral. But then so many of the patients are either lacking the funding because the individuals who do it are not taking insurance for obvious reasons,
Mhm.
or they can't take time away from their baby, or they don't feel comfortable ringing their baby, or they think they're going to be judged or judged and juried again, and they just don't make time to do the work until it has escalated,
Wow. Okay, well,
unfortunately.
yeah, I mean that kind of seems like the next step is rather than the suffering that goes on for years until they find someone like me, what's happening in terms of maybe trauma informed uh labor, right, kind of boots on the ground, working with people who are pregnant, like informing them of all of this so they can be proactive in their own process.
It would make sense. I can tell you that the doctors and the midwives at GW will come to us and say, you guys know the patients better because you're not restricted to 10 and 15-minute visits.
Right.
You tell us if there's something we need to do, we will support you. And they're so overwhelmed with
Mm, mm.
the systems they work in that they don't have time to add another thing to their plate, honestly.
Wow. Okay. Well, I asked. Thank, thank you for
Sorry, it's not a great answer.
well, but it's an honest answer, and it is in keeping with a lot of what I have heard over the years from clients.
Yeah, yeah.
Okay.
Anyone else? All right. So obstetrical trauma is when the patient is mistreated within the eyes of medicine, and specifically when human rights are not being upheld. So this would be threatening the client or ignoring the client, invasive or painful treatment against their wishes, a lack of consent, institutional racism, and of course, intergenerational trauma. And I don't think I need to explain what those words mean to this group, because that's why you're here. However, as again, I've been doing this for 27 years, I can think I've had at least 4 or 5 incidents where the provider intentionally ignored and or threatened the patient. And I bore witness to that. In one case, I reported it. The other cases, I did not, for a variety of different reasons. The patient and I worked on it, and then the patient reported it down the road. But this is something we're still seeing today, even with everything that's going on, which is unfortunate. Infant-related trauma, some of these are the same. Obviously, a NICU stay, a laceration from cesarean section, the likelihood of that happening is 1.7%. Nerve damage, I don't have a percentage on that. Nerve damage would usually be a brachial injury. Newborn needing, say, open heart surgery, or a newborn being born with an unknown congenital issue. More fingers than expected, less fingers than expected, a short arm, Fraser syndrome, several of those things. It's not uncommon for parents to believe that their child is actually suffering in the NICU, and that's why they try to spend as much time with them. But at the same time, when that child is actually discharged from the NICU and the parents bring them home, they are scared because that baby was in the NICU with 24-hour care, and now they're being discharged. And the parents think they need to give that child 24-hour care again. And they believe if they don't, the child might die. So seeing a lot of this also around NICU. Client quotes, these are things clients have actually said to me myself. I was treated like nothing. I was denied pain medication. They didn't believe how much pain I was in. I felt coerced into making a decision or was mocked. It was dehumanizing. I was offered WIC repeatedly, even though I didn't qualify. I believed it's because I was Latina and my partner was Black. I cried all over again every time the staff came in for routine infant visits, even though my baby had died. I felt raped, that my dignity was taken from me. When I shared my beliefs and wants, I was belittled and made to feel incompetent. And there's stories obviously behind each and every one of these, but if you put yourself in their shoes, you could try to relive some of the trauma or live some of the trauma that they themselves are experiencing. When, and Carol can speak to this better than I can, but some of those symptoms that we see are flashbacks, dreams, intrusive thoughts. It is not uncommon for individuals who have trauma not to go back to the place, that event where it happened. So if they get pregnant again, they go to a different doctor or a different hospital. They avoid the doctors, they avoid the hospital, they avoid having other children, thinking about it, all of those things. Oftentimes we see anxiety attacks, panic attacks. In extreme cases, we'll see dissociation from reality. Parents who will not breastfeed or choose to not bond with their baby. They don't trust themselves with the child or trust themselves on their own. Mark, what a cute kitty. And they no longer feel safe in general. And I think when we're talking with clients and we're asking how their recovery is going, and when they say, hey, I'm not breastfeeding anymore, it was too traumatic. My partner's the one who's taking care of the baby. Those are all flags for us to be aware of and to be noticing, because then we can explore into it, or if it's not appropriate, we can give those referrals whenever we can. Carol, you want to add anything to that? Nope. She says, I got it all. All right. So whose trauma is it? So this is kind of important. So primary exposure would be the person who experienced the trauma. That would be the patient themselves. Secondary, obviously, is anyone who witnessed that trauma. So that is the partner. That is the support people, the OBGYNs, the midwives, the doctors, the nurses. And by the way, 35% of all providers meet the criteria for post-traumatic stress disorder because of what they see in the labor and delivery room. And then third exposure would be all of you. That would be the mental health providers, lactation, family, friends, and colleagues, anyone who's working with these families, either during this time period or after this period, helping them to unpack it or even just support them on that journey. So for those of us who work with these families, please like take care of yourselves, make sure that you're doing what you need to do so that you can take care of the clients going forward. Short term, a lot of parents are hypervigilant. They are worried about protecting their bodies, or they're worried about protecting their babies. They're constantly checking to see if the baby's breathing, for example. Oftentimes, they will have breakdowns in their family relationships with their partner or with extending family members. Like I said before, bonding and attachment with the baby, breastfeeding can suffer. Any type of pain, even if it's getting up and going to the bathroom, dealing with a tear, reminds them of the trauma of the event. So then they avoid doing it. And this is where it sort of snowballs, because if we don't deal with it here, by the time they choose to expand their family and get pregnant again, now we're going into the next birth with all of this. And that child has been in this situation, and then this next child will be in that situation as well. Long term, many of these are the same. However, persistent negative thoughts, blame, lack of sleep, lack of concentration, feeling numb or disconnected, hopeless, detached, suicidal are all things that we see. And many, many people put on one face when you're talking to them. And then as soon as they're in their own space at home, whatever it might be, the curtains drop and the real part is exposed. I can think of at least 2 times I've been at a birth where in the process of the delivery, the partner has explained to me that mom has been suicidal. One, because she had a stillbirth with her first, and this was her subsequent pregnancy. The other one was a domestic abuse situation from a previous marriage. And we had to bring social work involved and the providers involved, and we had to surround them with care. Because once you know that, you can't just let that go. But it does happen. I'm not exaggerating here at all. So impact in the next verse, started to talk about that a little bit. So what we find is that parents will adjust their reality. So the first time they came in with a birth plan and they had all these ideas about how birth was going to go, this time they just want to come out alive. Doesn't matter what birth looks like. And oftentimes they will go to extremes. They will choose a C-section in order to guarantee the outcome, for example. Therapy is huge, preemptive or processing, or however we can get them into therapy, making sure that they learn how to vocalize their needs, be able to say, I matter, no, yes, this is what I want, this is what's important to me. We will, as doulas, we will help them to find a new provider or a new facility, or if they're staying at the same facility, by the way, you can reach out to the charge nurse or the medical team at the hospital, and you can explain to them, hey, I'm coming in with Susie. This is her due date. This is her situation. We need to make sure we're not in room 25. We need to make sure we don't go to triage, and we need to make sure we don't have Nurse Molly with us. And they will bend over backwards in many cases once you can verbalize what the issues are to make it safe for them. Not always true, but they try. If it's an anesthesia issue, you can actually reach out to the facility and you can have them get an anesthesia consult prior to the delivery so that their medical history, their anesthesia history can be exposed. And so the whole team knows what their needs are before they show up. We can, like I said, request different rooms, different providers. We can involve social work. And of course, when we open this up, hospitals and birth centers will oftentimes let some of their rules fall to the side. We can bring extra people into the room. We can bring clergy. We can bring therapy into the room. accommodations can be made if we know to make the request, which means the patient has to disclose it to us. They have to feel safe enough to do so. Providers. Oh, I'm moving fast. Cool. All right, providers. In the hospital setting, if you've been at a traumatic birth, let's say it's a demise, a fetal demise, the most hospitals will give that nurse 24 hours to 48 hours off shift and mandatory therapy. However, the OBs and the midwives don't typically do that, just the nurses do that because the nurses are in the room 6% of the labor, the providers are in the room 3% of the labor. However, the nurses, the doctors, the midwives, the doulas will have similar impacts where they may choose not to stay in a room that has a similar situation. They may find that they get nervous or have anxiety anytime a situation that presents that remotely reminds them of what happens. They don't trust themselves. They themselves can have the flashbacks, they can have the dreams, the intrusive thoughts. Oftentimes the hospitals will do case reviews, which is a great opportunity for everyone to say, hey, this is what happened, why it happened, and what can we do differently? Going back to what you were asking, Carol, that is a practice, but it only looks at it from the medical point of view. It doesn't look at it from the patient point of view. What I will tell you, and I know this to be true, if I'm at a demise where I've lost a baby, I will tell you, me, myself, I am jumpy for the next 5 births. Every time there's a hiccup on that fetal monitor, I have flashbacks. I get worried. If there's any reason to think that that baby might not come out vaginally, I'm going to potentially let the parents know that they have another option, a C-section delivery. And if I am behaving like that, the providers are behaving like that as well. And I have seen that in practice. So think about it. They're constantly exposed to chaos, crisis, suffering, even death. They are short-staffed. Right now in most hospitals, it is 1 nurse for 3 rooms, and the doctors are spread even thinner than that because when they're on call, they're dealing with all the triage phone calls, all the people who think they're in labor, the people who are in labor, and discharging those who delivered. And that's a lot on their plate. Plus, in many cases, they're working 36 and 48-hour shifts. So their cognitive ability is diminished as well, right? Most providers are married, so they have to either compartmentalize or they wind up bringing that stress into their own home and affecting their own family or affecting their sleep, and that makes them anxious and that encourages burnout, and we just sort of go through this ripple effect or this cycle again, which is not good for them and it's not good for the patients. So for all of us, no matter what our domain is, we need to identify our vulnerabilities. What are our strengths? What are our weaknesses? And they can be situational or they can be personal triggers. So for me, myself, I don't do well when I have a couple and the partner thinks the birth is about them. And I know that about myself. And when I know I'm going into a situation like that, I will bring a student doula with me and I will have them focus on the partner so I can focus on the birthing person. But you can't always know those things up front. So knowing what the facility that you're going into, what is their culture, what is their communication styles, and how is that going to potentially affect your client or yourself. Understanding their limitations and their practices. Does the hospital let women go over labor for more than 12 hours or 36 hours? Do they do inductions? Do they not do C-sections? All of those things. Is this a client or a provider that has issues around race or culture? If you think about it, a lot of Black and brown families want Black and brown providers because they feel more comfortable there and they think they can understand what racism is and protect them. Unfortunately, not always the case, but it can work in their favor sometimes. Knowing my own history or their history or the provider's history around trauma. I was at a hospital in DC about 6 years ago, and the doctor pulled me in the hallway. It was a doctor I was familiar with, and she goes, Ursula, I have an emergency. And I said, okay, what can I do? She goes, my husband's coming in by ambulance. He had a heart attack. I'm going to go down to the ED, make sure he's stable. I'm going to come up as soon as I can. Keep your room calm. If you need me, call me, right? And I said, great, let me know when you're back on the floor, right? So knowing that that's going on in the background, or knowing that my nurse was served divorce papers on her way into work that day, and that's going to affect her mood in the room. Um, Ask for help, whether it's in the moment or after the fact, or reach out to everybody's here. You need to surround the patient, surround yourself with positivity, support. We can't do any of this alone. So team up, do it together. A lot of these things are, I think, practices we already have. So after trauma, make sure that we're breathing into our bodies, ground and reboot ourselves. A psychological trip is called Name and Notice the Trauma. Hey, this is trauma. This is what happened. It helps you to put parameters around it. Process and validate the experience either with peers or with professionals. Make time to reconnect with yourself. And I think of that as um, both as preventative self-care and then also supportive self-care. So things that you can do before you go into these situations or deal with these clients, as well as how do you process it after the fact. Finding that balance between the two so that you can take care of yourself. Making sure that you seek help. I'm sure there's a bunch of people on this call that would be willing to talk to you and help you work through these things together. But most importantly, grief, trauma, fear is not linear. And so it can take years, it can be up and down, it can flash back 25 years later to go back to what Carol was saying. The body holds it, it doesn't go away until we work through it. This is a story I'm going to tell you guys just to tell you a little bit about what a doula can do when we're moving into a traumatic situation. So this little baby here, his name is Asa. He's now 14 years old. So let me just clarify. His mother, Leah, came to me and I was her childbirth educator for her first birth. And she had a C-section at a hospital in DC. And she came back to me and hired me as her doula for her second birth because she did not like how she was treated at her birth. And she doesn't feel that the providers took care of her the way it needed to be. So she goes into labor and I'm with her for about 42 hours. And when we finally get to the hospital, about 12, 14 hours in, the doctor pulls me in the hallway. Again, they knew me. And they said, hey, Ursula, this is a unique situation. Her pelvis is teeny tiny. We're not sure this baby's going to fit through, which this hospital never says those things. We just want you to be aware. We're going to give her every opportunity, but just put your radar up. So we get there, we push for 4 hours, the baby doesn't descend. We decide to call it for a C-section. So we turn off the epidural, we keep the epidural on, we turn off the Pitocin, we just sort of let everything quiet down. And about 30 minutes into waiting for the operating room, her girlfriend calls me in labor. And so Leah knew it was her girlfriend, Amy. And Leah said, I'm good. I've had a C-section before. Go to Amy. Go take care of Amy. We'll talk tomorrow. And I go, are you sure? Yes. Great. I'll call you later. I left. I went to Amy's birth. She was going very, very fast. I finished that birth. I got to my house and there was a bunch of messages on the phone from nurses at the hospital where Asa was. And the message was, Ursula, we need you back at the hospital immediately. Didn't know what was going on. Didn't know what happened. Nothing. Got to the hospital, got to the nurse. The nurses pulled me on the side and they said, the baby is atypical. We're not sure the baby's going to make it through the night. Mom had complications in surgery. She's not coming out of anesthesia and dad's losing it. I said, okay, now I know what I'm in for. So I walked into the room. I sat with dad. We started talking about what was going on. And then he decided to take a nap. So I went into the hallway. The doc found me. She grabbed my arm, pulled me into another room. And I'm like, shit, I'm in trouble. And so Katie, the doctor, turns to me and she goes, I'm pissed. And I go, okay, did I do anything? She goes, you didn't do anything. But Leah should have never labored. And the previous doctor did not fill out her C-section paperwork properly. Leah has an abnormal pelvis, one ovary, one kidney, and she has a unicornate uterus and should never have labored. And we're not sure the baby's going to make it. And I go, okay, what's going on? And so she takes me to meet the baby, and this is Asa. So Asa has a bird beak mouth. He has a very like a beak nose. He is got a cyst under one eye. He has an eyeball under the other. He has a big bash on his forehead. He has a pigeon chest. Comes to be that Asa has Fraser syndrome. He's the 8th baby ever in the United States to be diagnosed with this. A very rare congenital issue. Both parents carried the marker. Interestingly enough, these babies don't typically make it through the night. And if they do, they typically only make it for about 3 to 8 years before they die because most of them have severe organ damage. Ace's organs were fine. He's blind. He's a level 4 autistic. He's living a great life right now, but it was a real struggle. So I was there as Leah came out of anesthesia. I was there as we went back to the NICU. We met with her baby. I wound up spending like another 12 hours with them that night. When they got discharged, I went to the house for a postpartum visit, and I wound up working with them extra postpartum. And part of what we did is we practiced looking at the baby, naming the baby, naming what was going on with the baby. Then the next time I came back, we practiced going out in public with the baby in a stroller, but the baby completely covered. So no one could see the baby, so she could get over some of her fear. The next time we uncovered the baby and we just walked in the neighborhood. And then the third time we took the baby out in public and I helped her to work through everyone pointing and looking and saying, what's wrong with your baby, right? I tell this story because on ultrasound, we couldn't tell any of these things were wrong with this baby. It was a complete surprise. And he's having a very full life. No concerns there. The medical team, Carol, did not know what to do. They didn't know what to say. They didn't know how to handle the situation. I mean, they handled it within medical. In the hospital, I made requests to allow extra people to get their family clergy person into the hospital to pray with them, to pray with the baby, to give the baby last rites in case the baby didn't make it through the night. Like these are things the staff wasn't thinking about because all they were thinking about was medically managing Leia and then medically managing Asa. They weren't thinking about what did dad need, what did baby need, what did mom need in this whole process. And so because I didn't have to do any of that medical management, I was able to think about everything else. And I was able to help advocate for the family and make some of those requests. Here's my information. You guys can reach out at any time. That's my work number. Happy to talk to you. Happy to answer any questions anybody might have. Did I go too fast? I have a tendency to do that.
No, you're great.
Thank you.
Yeah, it was great.
I'm new to this group. This is actually my first meeting, and this isn't really my practice world, or I stay in my lane. I don't see this, so just interesting to listen to you. Appreciate you, Ursula.
You're welcome. Welcome to the group.
Well, I really appreciate, Ursula, everything that you covered, because I think what we forget is, and Mark, I'm sure you've met lots of these moms or maybe children that have grown up from these situations. And so this is our whole world, our community, and we don't always realize all the trauma that they've experienced. So, I love the Robin Williams quote, "Be kind always. Everyone's fighting a battle we know nothing about."
I got an interesting story. My parents, they got married later in life, but they had twins on, of all things, Halloween, and they were 24-week preemies in 1959. And it was Beth and Bruce. So Bruce died the same day, Beth died the next day. And it was interesting in that era, it was kind of like taboo to let the mother see the dead infants.
Yep.
And it was just, weird. Like dad was able to see them, but they wouldn't let mom. And the good news, my parents lived to be 94 and 95. And they lived to 2018. I lost them. And my sister Mary Beth is a nurse, and I'm a chiro neuro. And so mom had a stroke and left middle cerebral stroke, and she died about 3 weeks later. But my sister said when she was able to spend the last hours with my mom, it's like, now you can finally meet the twins. But I mean, that was, just we hopefully are doing better now, but I
We are
mean,
doing much better. So
yeah, but I mean, it's
here's,
just some of the weird stuff that they used to do back in the 50s and 60s, and just like your story. So I appreciate you.
you're welcome. And the hospitals, they are skilled around that. Not all of them the same. I did work with two of the local hospitals in DC to expand their reading list and their referrals, but they do memory boxes. They do give the parents the option and encourage them to hold them. They have hand knitted clothing that the babies can put
Mhm.
on and the parents can then keep it, or the baby can be um, taken to the funeral home in that. They do footprints. Now I Lie Me Down to Sleep is a volunteer photography program that comes out and does black and white high resolution photos. And we intentionally do black and white because of the blood pooling in the
Sure.
device. Um, that the hospitals definitely have skill around.
Do you practice back east?
I moved out here to Arizona 3 years ago, but
Okay.
I have most of my teams in DC, Maryland, and Virginia, and then I have a small practice out here.
Okay.
Yeah, speaking of which, if you know anybody that needs doula help, that's what the think tank's about, is to spread community and spread word to help support each other. So
And
welcome
then
to the group, Mark, and thank you, Ursula, for doing this informative presentation.
And one thing I can give to those of you, I mean, those who are listening, as well as the ones that are present here, is if you do have a client coming to you for trauma, if they have newborn pictures of what the baby's skull looks like and their head at delivery, as well as their operative reports, I can interpret that for you. I can tell you what position the baby was in and where they got stuck in the pelvis, which can help you, Carol, to either process that, or Mark to do the adjustments to potentially avoid that in the future, or whatever it might be, so that we can get closure for the parents, but also put them in a better place physically, mentally, and emotionally if they have another child or if they don't. So that's an offer I make to everybody.
Yeah, no, that's like connecting all our worlds is wonderful. That's the that's what it takes. Any other questions?
I just wanted to pop on. Hi, Ursula. I'm Paris. I'm a
Yes.
prenatal pediatric chiropractor.
Awesome.
So I loved your presentation, and it just aligns a lot with just, we believe in stress. It isn't just physical, it's chemical, emotional as well too. So I loved what you were talking about, and I feel like a lot of this is just brushed off. And as a provider, we understand like trauma is, subjective as what that person is experiencing, but it's cool to see kind of all the other realms, other things that I haven't even thought of, and even kind of hearing these different stories and kind of being that tertiary form of like trauma too. So loved your presentation, and it was really great. So thank you.
Well, I hope I didn't pass the trauma on to you guys, but
No,
I
not
just
at
wanted to
all.
sort of give an example of like what that can look like on both ends.
Mhm.
I mean, Paris, this is exactly your niche. This is what you're
Yeah.
seeing, right? So you two need to connect more later.
Please do. Happy to.
Paris, what area of town do you practice?
In Scottsdale, I actually just saw your post today.
What area of Scottsdale are you?
North. So I'm in North Scottsdale. I'm off Raintree and North Site,
Oh, you're
So
right on.
you're
I'm
right near
Cactus
me,
Haven.
Paris.
Yeah, I
right
mean,
around the corner.
yeah, I mean, I'm kind of like, this is really interesting to me, but it's like I love referrals, but the patients I don't really see are pregnant, because I'm a big laser guy, I'm a big neuro guy, and those are big tools of mine, and I can't really do a lot of adjusting on a pregnant woman like this. So that's why I just stay in my lane. I don't do pediatrics. Do you know Connor Bohr by chance?
I know him. Yeah.
Okay, good. All right. Well, I will friend you on Facebook, okay?
Perfect. Amazing.
And Paris,
Okay.
are you doing an in-person in October?
So I think I would like to do an in-person. I think I need to have a bigger space for it. I think it'd be cool to do almost like a live presentation of the scans so that we can interpret it and then just be like, this is how I would adjust, or like how we would go moving forward. So I think that's what I'm toying with. But
Well, let's
yeah,
see if
to
we
be
can find someone
determined.
to host you so we can all be there and meet in person.
Yeah.
Yay. All right. Well, thank you so much, everyone, for joining. And thank you, Ursula, for the wonderful presentation and all the comments.
Thanks,
Thank you.
everybody.
Yes,
All right.
thank you.
Have a good night.
Thanks. Bye.